Hi, and welcome back to the Heart Failure series. Over the next several lectures, we're going to discuss in great detail different types of GDMT medications, including dosing and uptitration, when to use these drugs, when to hold back, clinical pearls, the real evidence behind why we do what we do, what are the gaps in clinical care right now. All right, let's talk about RAAS inhibitors. So, ACE inhibitors, ARBs, and ARNIs. Recommendations: there's a 1A recommendation for HFrEF patients with NYHA 2 to 3 to use ARNI. 1A recommendation to use ACE inhibitor or ARB if ARNI is not tolerated. But if a patient is on ACE inhibitor or ARB and ARNI has not been tried, then it's a 1A recommendation to replace it with an ARNI to further decrease both morbidity and mortality. And then there's class 3 recommendation or harm. If a patient has a history of angioedema, then don't use ACE inhibitor or ARNI. And ARB in this case remains an option, but there's caution that some patients actually have had angioedema even with an ARB, so that's something to be cautious about. When switching between ACE inhibitor and ARNI, there needs to be a 36-hour washout period. Otherwise, there's an increased risk of angioedema. And then moving on to what is an ARNI? So it's a combination of ARB plus neprilysin inhibitor. Entresto, which we use most commonly, is valsartan plus sacubitril combination. So ARB you know, but what about neprilysin? How does that work? So basically, neprilysin is an enzyme that degrades natriuretic peptides such as ANP, CNP, BNP, other vasoactive peptides, bradykinin. And when you inhibit this neprilysin, all of these that it acts on will accumulate. That is the beneficial effect that we see because, for example, the natriuretic peptides cause diuresis and natriuresis. And then vasoactive peptides cause vasodilation. There's also some RAAS inhibitory effects and sympathetic system inhibition. All of these act in a complex way and provide the benefit that's added with the neprilysin inhibitor. Now, why not use ACE inhibitor with neprilysin inhibitor? So both of these agents would increase the risk of angioedema. And there was actually a drug that was initially developed with such a combination, but during development it was discontinued because of increased cases of angioedema. So it's only used with an ARB. Of note, in post-MI heart failure patients, neprilysin activity has actually not been shown to be increased. So inhibiting it does not necessarily make sense from a pathophysiologic standpoint. And we'll see how that translates to clinical medicine as well. Also, studies have failed to show additional benefit of ARNI over ACE inhibitor or ARB in advanced heart failure patients. So your NYHA4 patients. And the hypothesis behind that is that these patients have a blunted response to the natriuretic peptides by that point. So inhibiting it does not give you an added benefit. And we'll go into the exact evidence on this in a little bit. So let's talk about the evidence in general. The Paradigm HF is one of the main trials for ARNI. They took symptomatic heart failure patients and randomized them to Entresto versus enalapril. There was an additional 20% relative risk reduction in composite outcomes of cardiovascular death and heart failure hospitalization. And there was an absolute risk reduction of 4.7%. There was an increased hypotension and angioedema seen with ARNI. In Pioneer HF trial, they took stabilized acute decompensated heart failure patients, and the primary outcome was improvement in NT-proBNP, which was seen. So this was also a positive trial for ARNI. What about pre-discharge versus post-discharge initiation of Entresto? So there was this transition trial that looked at this, mainly looked at the safety outcomes, which were pretty similar in the two groups. So based on these findings, you can justify that it's pretty safe to start the patient before discharge on Entresto. And there's further studies like the
strong trial, which we'll go over later on, which shows that, rapid initiation and up titration of all the GDMT actually is pretty beneficial to reducing hospitalization. Then there is the post MI heart failure question. So is it beneficial to add ARNI for these patients, or is ACE and ARBs enough? So there was Paradise MI trial, which was a large RCT that compared starting these patients on Entresto versus Ramipil within a week of their MI if they also had LV dysfunction, so EF less than 40% or signs of pulmonary congestion. Of note, ACE inhibitor and ARBs in this population already has a very well established RCT based evidence for support. So they needed to prove superiority of Entresto on top of ACE inhibitor. In this study, they did not find a benefit in the primary outcomes of CV death and heart failure hospitalization, and there was a similar safety profile. In another study, there were also similar findings that ARNI does not add additional benefit. In this case, they looked at if ARNI was contributing to LV reverse remodeling as a surrogate marker, and they did not see a beneficial effect. So based on these real world studies, plus the pathophysiology that we discussed. So in this patient population, it argues against the use of ARNI. Then we have the NYHA4 class patients or advanced heart failure patients. Is there a benefit of ARNI in this case? There was a LIFE trial which compared Entresto to valsartan, and there was no difference in clinical outcomes or NT-proBNP, and actually there was an increased hyperkalemia episodes noted, and 50% of these patients were unable to tolerate ARNI. So there's a limited role in this patient population, but ACC still recommends it in their 2024 guidelines based on expert consensus for all the patients who are able to tolerate it. So if we had to put some numbers on what the reverse remodeling parameters look like when we start a patient on Entresto, we have the PROVE-HF trial, which took HFrEF patients, started them on Entresto, and then compared their parameters at 12-month endpoint. In terms of ejection fraction, the mean EF changed from 28% and improved to 38%. Left ventricular end diastolic volume index improved from 86 to 74. Similarly, there was improvement in left ventricular end systolic volume index, left atrial volume index, and E to E ratio, and E to E prime ratio. Similar findings are also shown by the Evaluate HF trial. So these findings really tell us that it's very important to optimize the patient on GDMT before considering things like percutaneous edge-to-edge repair of the mitral valve or an ICD, because they may improve and not end up requiring these procedures. There is caution for patients with eGFR less than 30. You have to start them on low dose, 24-26 milligram, and titrate up to target dose. Similarly, for moderate hepatic impairment, start at a low dose and go up. And then also caution with systolic blood pressure less than 100, renal artery stenosis, and volume depleted patients. In fact, if your patient is on the volume depleted side, you may be benefited from lowering the dose of diuretics and then starting the Entresto, so it will be better tolerated. Let's look at some of the doses. So for ARNI, Entresto start at 24-26 or 49-51 BID dosing, and then target dose is 97-103 BID. Not going over all the ACE inhibitors and ARBs, but the common ones. So we have enalapril, you start at 2.5, go up to 10 to 20. Lisinopril, start at 2.5 to 5, go up to 20 to 40. For ARBs, we have losartan, which is kind of like 10 times the lisinopril dose. So 25 to 50 is where you start, and you go all the way to 150. And for valsartan, you start around 40 BID, you can go all the way up to 160 BID. All right, that was all for RAAS inhibition for heart failure patients. Let me know what you think, any questions in the comments, and I'll see you in the next video.